Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry, and I am your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services, Administration on Intellectual and Developmental Disabilities, and the Florida Developmental Disabilities Council, Incorporated. This is the 11th installment of our 12-part series occurring every Tuesday night at 6 p.m. Eastern Time through October 9th. Each part of this series is accredited by the American Academy of Family Physicians for 1 credit hour of AAFP prescribed credit and is recognized by the AMA as equivalent to 1 hour of AMA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org and are accredited for CME credit for the next 2 years. If you are not a physician, you may also obtain a certificate of completion. Just remember that we are only able to award continuing medical education credit for this webinar series. After the presentation tonight, there will be time for questions, so if you have any questions, please type them in the question box of your control panel as you think of them, and we will get through as many of these questions as possible during the time we have left. Our presentation tonight covers one of the most important topics seen in the field of developmental medicine. To put it simply, it's about drugs and behavior. Study after study tells us that people with intellectual and developmental disabilities are at a very high risk of polypharmacy, and that one of the biggest reasons for this is the misdiagnosis or inappropriate treatment of behavioral concerns that are brought to the physician's attention. While behavior concerns are almost always valid, they do not always signify that there is an underlying psychiatric illness. Sometimes the behaviors are a manifestation of pain brought about by underlying medical illness, or they may even be attributed to a change in the patient's environment. Moreover, even if a psychiatric illness has been correctly diagnosed and treated with medications, these medications may have side effects that can result in additional changes in the patient's mental status or behavioral status. Tonight's presentation will discuss these issues in detail and hopefully give you some additional tools to make sure that your patients with IDD are being treated appropriately for behavioral concerns. Our presenter tonight is Dr. Stephen Rudrick. Dr. Rudrick is a nationally renowned professor and vice chairman of psychiatry at the Case Western Reserve University School of Medicine in Cleveland, Ohio. His career has involved providing services to persons with ID and dual diagnosis and teaching medical students and psychiatric residents about IDD. He is a co-author of 40 peer-reviewed articles and 10 book chapters addressing IDD, and is the recipient of the 2011 Frank Menelacino Award for the National Association of the Dually Diagnosed. So without further ado, I'd like to turn over the presentation to Dr. Rudrick.
Thank you, Dr. Holder, and welcome to our presentation this evening. After that, thank you for that very nice introduction, and I would like to say that you pretty much summed up my talk, so I'm not sure that we've got another hour's worth of information, but we'll try to muddle through. I'd like to thank Dr. Holder for the invitation to join you this evening, and also Mr. John Hood for his behind-the-scenes expertise in putting this seminar together. I'd like to thank the AADMD, the Florida DD Council, and the Florida Center for Inclusive Communities for their sponsorship of this series and for the opportunity to talk with you tonight. What I'd like to do is provide a broad interview or overview of the concept of the dual diagnosis of psychiatric illness in people with intellectual and developmental disabilities, talk a bit about the diagnostic process and the importance of diagnosis, and then move on to some issues in psychopharmacology. We're going to go into the various classes of psychopharmacology that we use in and sometimes misuse in people with IDD, talk about some common effects and side effects, some things to think about before, during, and after your psychopharmacologic prescribing, and then end with some guidelines from the World Psychiatric Association about how to practice psychopharmacology in these patients and then hopefully leave some time for some questions and try and get some dialogue going at the very end. So without further ado, here we go. So we're going to talk about or begin our discussion tonight with the concept of the dual diagnosis. This is the notion that individuals with intellectual and developmental disabilities can and do suffer from a wide range of both psychiatric illness and behavioral disorders. When you're talking about the dual diagnosis, we have to make sure that we're not talking about another area in psychiatry, which is the dual diagnosis of substance abuse and mental illness. We in the IDD field created this term or coined this term first, and we're going to hang on to it, although the number of people in our country with comorbid substance abuse and mental illness is much larger, and if you do a literature search, you're going to find many more hits in that area. But the original concept of the dual diagnosis was coined by Dr. Frank Mendelacino, the chair of the Combined Departments of Psychiatry at the University of Nebraska and Creighton University in Omaha, who in the early 1980s came up with this concept. And over time, study after study after study have shown that people with ID have a wide range of comorbid psychiatric and behavioral disorders. Depending on the group that you're studying, it looks like somewhere between 25 and 40% of persons with ID have comorbid psychopathology. So that what I like to talk about in this regard is what I call the 1/3 rule. If you can just remember that about 1/3 of people with intellectual and developmental disability will have some comorbid psychopathology that will bring them to evaluation and possible treatment. That's a lot of folks. We think that if a conservative estimate in the United States is that about 1% of our population has an intellectual and developmental disability, that's about 3 million out of our 300 million population. And if 1/3 of those folks have a comorbid dual diagnosis, we're talking about at least 1 million individuals, mostly living in the community, spread across our country, who have this comorbid disorder. This is a picture of Dr. Mendelacino, who served all of those roles in his chair position at the University of Nebraska, and is credited with coining the concept of the dual diagnosis. Before we had the dual diagnosis, we had to deal with what has come to be known as diagnostic overshadowing. This was a term coined by Dr. Stephen Reiss and co-authors similarly in the early 1980s. And this notion was that whatever someone with an intellectual or developmental disability might do, however they might behave, could be ascribed or would be ascribed particularly to or solely to the intellectual disability itself, and not to the presence of a comorbid psychiatric or behavioral disorder. That is, the diagnosis of ID would overshadow any other possible comorbidity. So if someone with intellectual disability had a lot of crying spells, or stayed up all night, or laughed excessively, or was aggressive, or was self-injurious, or name your symptom, it was ascribed to the presence of the ID itself and not to any dual diagnosis. And we're still guilty of this. We still see people who allow or think that the ID itself really accounts for any and all behavior or symptomatology shown by someone with ID. And this concept is called diagnostic overshadowing. So on to the dual diagnosis. As we've noted already, it looks like people with ID are subject to the entire spectrum of psychiatric disorders. But as you know, if you work in this field, although these disorders in our patients are very common, they're often not appropriately identified, and that determining an accurate diagnosis is especially difficult as the level of intellectual functioning declines. Let me go back to this one. That is, as the person's intellectual ability decreases and as functional language allowing them to share with us what their experience is decreases, it becomes excessively hard or difficult sometimes to determine an accurate diagnosis. And this has been outlined by these two authors who have related that the type and the presence of and the type of psychiatric illness in people with ID has a lot of issues or items or circumstances which will in the end result in whatever dual diagnosis they may have. We think that the type of psychiatric illness depends on what is the cause of the intellectual disability? Is there a known etiology? What is the developmental level of the individual? We know that for certain types of psychopathology, one must have symptoms that are in excess of whatever the developmental level of the person in order to function as a psychiatric illness. Obviously, life experience. We tend sometimes, I think, to discount what stresses, strains, traumas may occur in the life of a person with ID as it relates to developing psychopathology, but obviously life experience is very important. Obviously the age and the gender of the individual have a lot to say. We know that certain psychiatric disorders are more or less common in men versus women. Some begin in childhood or adolescence, others in young adult, and some not until middle or later ages. So the age and gender are important. The diagnostic strategy employed. I'm going to share with you later in our presentation a couple of diagnostic strategies that we have available today for trying to arrive at accurate diagnoses. And then the next one is kind of controversial, the experience of the examiner. We would love that if in diagnosing people with ID psychiatrically, a novice in the field would be just as good or have as much validity in arriving at a diagnosis as some more seasoned individual, but unfortunately this doesn't look like it's really the case. The setting is important. We're going to talk a little bit more about that later in terms of how that affects presence, absence of psychopathology, and then obviously treatment already in place. It's unusual for most of us who work in the field to see individuals who are presenting for the first time for psychiatric examination, so that typically by the time a person gets to you, they have already been seen by other clinicians, may already have treatments in place, there may be a history of treatment. So the success or failure of that treatment can also obviously affect what type of psychiatric illness you're going to be able to identify. Most of you are familiar with the Diagnostic and Statistical Manual of Mental Disorders. We're currently on, as you know, the 4th edition. It means we didn't get it right the first 3 times. And we're on the verge of, or on the eve of, our DSM coming out with its 5th edition, probably May of 2014 is the launch time. The DSM, as good as it is, and as much as we think it's been a dramatic breakthrough in the field of general psychiatry, has its limitations when we try to apply it to people with intellectual and developmental disabilities. And in general, I think that it's hard to utilize in people with ID who have an intellectual ability, an IQ in the low, moderate, or lower range, and or who lack expressive language. Much of the DSM calls for the patient to be able to relate to the clinician what their clinical experience is, what their inner emotional circumstance is. And in many of our patients who are unable to do that based on a lower IQ and or lacking expressive language, the DSM becomes less and less applicable to those patients. So that we now have available to us a couple of modified diagnostic manuals. The one you can see on the right hand of your slide is the DCLD, the Diagnostic Criteria for Learning Disability. This is a text used in the United Kingdom. It's been around for probably about 10 plus years, and it is intended to be used for adults with mild and moderate intellectual disability. It's a listing of modified diagnostic criteria that have been taken from the ICD, the International Classification of Diseases, psychiatric section. On the left, you can see the newer manual used primarily in the United States, the DMID, Diagnostic Manual for Intellectual Disability. This again is a DSM-based modification or modified manual, which starts with the DSM diagnostic criteria for all of the psychiatric disorders, and then offers modified criteria for use in people with all levels of intellectual and developmental disability. This text was published cooperatively by the National Association for the Dually Diagnosed and the American Psychiatric Association. It has been around since 2007. If you are in the field, you've probably heard of it and may be using it. It does offer modified criteria for many psychiatric disorders. However, as you may know, if you've used this manual, it does not offer modified criteria for all psychiatric disorders for use in people with ID, so that there's still more work to be done in terms of coming up with these better and more specific diagnostic systems. And then I like to show this slide when I'm presenting this type of data. It's probably the best single field test looking at the incidence of psychopathology. It's a study by Cooper, published in the British Medical Journal about 5 years ago. Dr. Cooper is a psychiatrist in the United Kingdom, and one nice thing that can be done in the UK is large catchment epidemiologic studies. In this study, Dr. Cooper and co-authors studied over 1,000 adults with ID who were living in the community and did independent psychiatric diagnostic examinations of those individuals with different examiners blind to each other using these three diagnostic systems: the DCLD that I presented on the previous slide, the ICD-10, and the DSM-4-TR. And what you can see there is that using the DSM-4 text revision and the ICD-10, it looked like somewhere around 15–16% of those 1,000 adults with ID had a diagnosable psychiatric condition. When you use the more specific DCLD, the Diagnostic Criteria for Learning Disabilities, specifically geared towards making these diagnoses in people with intellectual disability, it essentially doubled the hit rate for psychopathology, showing that, at least in this sample, using a more specific diagnostic system, was able to identify to a greater extent the psychopathology involved. And this slide combines a number of studies looking at what is the prevalence of psychiatric disorders in people with intellectual disability. It looks like several specific disorders tend to be more common in people with ID than in the general population. And there I list some specific disorders or categories that tend to be overrepresented in patients with intellectual disability. For example, attention deficit hyperactivity disorder, mood disorders, psychotic disorders, anxiety disorders, all at higher prevalence rates than we tend to find for these disorders in the general non-ID population. You can see some pretty wide ranges for these disorders because these numbers are taken from compilations of epidemiologic studies trying to kind of look at prevalence rates. Conversely, there seem to be some disorders that are less prevalent in people with intellectual disabilities, such things as substance abuse disorders and classic eating disorders. Obsessive compulsive disorder, OCD, is probably fairly prevalent in our populations, but its overlap with autism spectrum disorder makes it more difficult to kind of tease that out in terms of figuring out true prevalence rates. And then a diagnosis we're going to see much more of in our specialty, that is dementia. Dementia looks like it's more prevalent and with early onset in persons with ID than in the general population, even when we exclude or eliminate patients with Down syndrome who we know develop dementia and all of the Alzheimer's type at a much earlier age. And then the real confusing thing in our field have to do with how and when and how often and under what circumstance we're able to diagnose personality disorders and behavioral disorders. These are more difficult to quantify. Both the DMID and the DCLD offer some modified criteria for these two disorder categories, but they agree that they're more difficult to accurately identify in individuals with intellectual disability. And then I can't leave this diagnostic area without mentioning this concept of the behavior phenotype. This is the link between the genetic underpinning of intellectual disability and consequent psychopathology and behavior. And the definition of the behavioral phenotype is the observation that a particular genetic etiology of intellectual disability may ultimately predict a specific psychopathologic course. It may be able someday to say that if we know someone has Down syndrome or Fragile X or Prader-Willi or Williams syndrome, that we can make some informed guesses about what type of psychopathology, what type of psychiatric disorder, what type of behavioral disturbance that individual may suffer at various stages of their life trajectory, based on knowing what the genetic etiology of their intellectual disability is. And so the field is really moving in this direction of not just kind of lumping all persons with ID as one homogeneous sample, but trying to tease out specific genetic etiologies or underpinnings for intellectual disability, and then be able to say how that might affect the types of psychiatric and behavioral disorders we see. And this may be a key slide in this slide set. That is that we try to make a specific distinction in the diagnostic assessment of our patients between whether they have a psychiatric illness or whether they have a behavioral problem or whether they have both. As we've noted, that we should not automatically assume that all difficult behaviors are or difficult problems in persons with ID or behaviors. That would be diagnostic overshadowing. And then obviously it's possible for an individual to have both a psychiatric illness and a learned behavioral problem. So if there's one take-home message from tonight's presentation, it would be this, and we could all go home early. That is that psychotropic treatment of people with ID should start with making an accurate psychiatric diagnosis. If we can make a confidently arrived at, a well delineated and supported psychiatric diagnosis, it appears that psychiatric treatment flows pretty much like it would for treatment of that same disorder in somebody who doesn't have an intellectual disability. So we can use antipsychotics to treat psychotic illness. We can use antidepressants to treat depressive illness. We can use the selective serotonin reuptake inhibitors for obsessive compulsive disorders, mood stabilizers for bipolar illness, etc. So if we can arrive at an accurate psychiatric diagnosis, then treatment, psychotropic treatment should flow from that presence. And as we've talked about, it's getting to that accurate psychiatric diagnosis where the problem often lies in this work. So that historically, because of that difficulty, we've often provided psychotropic treatment that has been symptom-based. We end up treating symptoms such as aggression or self-injurious behavior or insomnia or agitation or something that's really a symptom that could occur from a number of diagnostic possibilities, rather than being able to do disorder-based treatment. Again, if we can arrive at a specific diagnosis of a specific psychiatric disorder, we can treat depression or psychosis or anxiety or mania, but much of our treatment has remained a symptom-based type of treatment. And here's an important slight digression that I think is necessary, and that is way before a clinician should try to differentiate a psychiatric disorder from a behavioral problem, we must do an investigation for the presence of a medical illness that may be presenting in a behavioral manner. As you know and live every day if you work in this field, people with ID often have a lot of difficulty or might be completely unable to report any kind of medical discomfort or distress. And as a result of that, tend to act out their discomfort so that the first person to observe or learn of some change in their status or behavior can be a direct caregiver, it may be a family member, it may be a behavior specialist. It's not that these individuals are necessarily presenting to a mental health specialist once they've had a good medical exam to rule out the presence of some medical condition that may be presenting in a behavioral or psychiatric manner. And as you know, if you work in this area, there are a number of medical issues that commonly present behaviorally. Pain is a big one. Pain from any source can be something that a person with ID will act out with either agitation or aggression or self-injury or insomnia. Pain can be arthritic pain. Dental or oral pain is probably dramatically missed in our patients. Various etiologies of abdominal or menses-related pain, headache of various types. I know that we miss probably a lot of migraine. This is an uncommon diagnosis in people with intellectual and developmental disability, even though we know that it's a very common problem affecting the general population. There's no reason to suspect that people with ID are protected from having migraine, and yet it's not something we think of or look for very much. So we just need to maintain a very high index of suspicion when we're before we practice anything psychotropically. Other medical issues commonly presenting behaviorally may be various sensory deficits, visual deficits, or hearing loss. Other kinds of environmental hypersensitivity can be presenting behaviorally. Other medical illnesses to think about are such things as episodic seizures, infection of any source, particularly urinary tract infections or upper respiratory infections or ear infections that may be acted out. The individual may not be able to present that they're having pain on urination or ear pain or dental pain or other infectious sources of discomfort. Diabetes, thyroid illness, various allergies. Again, all things to be considered and ruled out before we ascribe the problem to a psychiatric or behavioral disorder. Other illnesses, various GI disorders, vitamin deficiencies, sleep apnea, probably very common in our patient population, but underdiagnosed, cervical neck disease, and then finally, as something we're going to spend a lot of time talking about tonight is the side effects of medications that a patient may already be taking that are presenting in a way that looks like they may have a psychiatric disorder or a behavioral problem, but may in fact be the side effect of medication. Moving on from that, with that large kind of disclaimer and caveat that we need to have an high index of suspicion, particularly in people with ID who have no ability or limited ability to tell us kind of if they're hurting, where they're hurting, or how they're hurting. We're going to move on now and talk about the major classes of psychotropic medications, and the next series of slides is really outlining these medications by class, by name, and then finally ending with what some of the common side effects are so that you can be thinking of these things. It's unusual for me. I'm not sure about our audience, but it's pretty unusual for me to see a brand new patient, unknown to me, who's not already taking a psychotropic medication or 2 or 3 when they present for the first time in my office. So one of the things we need to have a high index of suspicion about is whether whatever presentation they have might be ascribable to the medicine they're already taking. Excuse me. So Probably the largest class of medicine prescribed to people with intellectual disability are the antipsychotics or the neuroleptic medications. We divide those into first generation and second generation agents, and we'll talk about that later. A second class are the antidepressants. The oldest antidepressants, or ones we use very little anymore, are the monoamine oxidase inhibitors. I grew up in the area of primarily treatment with tricyclic antidepressants. In the early 90s, we began having medications that are in the class of the selective serotonin reuptake inhibitors, and then there are some other antidepressants. The mood stabilizers, lithium is the oldest and best known of the mood stabilizers, and in the last couple of decades there are a number of anticonvulsants which also have mood stabilizing properties and are also often used in people with ID, either with or without comorbid epilepsy. The anxiolytics are primarily the benzodiazepine anxiolytics, but buspirone is a non-benzodiazepine anxiolytic sometimes used. And then sometimes antihistamines are used as anxiolytics. And then finally, the various classes of stimulant medications and other psychotropics. So I'm going to run through these very quickly. I think you've heard of most of these. This is just to kind of reacquaint you with what medicines are considered in what class. These are the generic and brand names for the first generation antipsychotics, still widely used today, probably overused in patients with intellectual disability. These are the second generation antipsychotics, beginning with clozapine in the early 1990s and leading up to the most recent introduction of iloperidone in 2009, and they're in their roughly in the order of their going back and forth side to side, the order of their introduction into the marketplace. Here are the side effects, the common side effects of antipsychotic medications. Many or most of them cause sedation. Many of them or all of them can cause what are called extrapyramidal side effects, such things as acute dystonia, as muscle stiffness. Akathisia is the motor restlessness or an inner urge to move that we see often 2 or 3 weeks into treatment with an antipsychotic. All of them can cause a drug-induced what used to be called pseudo-Parkinsonism. It's not really pseudo, it's a drug-induced Parkinsonism manifested by tremor and bradykinesia and rigidity of the muscles. And then finally, in chronic use, can cause tardive dyskinesia, abnormal movements of the mouth or tongue, or sometimes trunk, in the patients treated chronically over long periods of time with antipsychotic medications. And then many of the antipsychotic medications in their own right can cause anticholinergic side effects, commonly constipation, urinary retention, a blurring of vision by pupillary dilatation, and dry mouth. And as some of the, if we have any dentists or oral surgeons on, we know how the consequence of the drying of the mouth and the changing in the acid-base balance of the mouth can lead to dental caries and mouth infections and a lot of dentition problem as a result of the anticholinergic side effects of many psychotropics. The newer antipsychotic medications, primarily the second generations, can also cause in the old days, when I was I'm going back a slide here, when all we had were the first generation antipsychotics, we worried primarily about sedation, extrapyramidal side effects, and anticholinergic effects. Today, with the second generation antipsychotics, we have the additional worry about this metabolic syndrome that all of these medicines as a class can cause increased appetite, often weight gain, sometimes excessive weight gain, hyperlipidemia, insulin resistant with glucose intolerance, and sometimes frank diabetes. And this metabolic syndrome looks like it's going to end up dwarfing the old EPS in terms of the actual consequences of these drugs used chronically, because these are really life-limiting, sometimes life-ending side effects. And it looks like also all of the second generation and perhaps some of the first generation antipsychotics elevate the risk of cerebrovascular accidents in patients who are older, particularly if they have comorbid hyperlipidemias and hypertension. Clozapine is a atypical or second-generation antipsychotic, which in the right hands can be a revolutionary drug. It's probably the best of the second-generation antipsychotics, particularly for the treatment of negative symptoms in psychosis. It, however, as you know, has a significant life-threatening risk of granulocytosis occurring in about 1% of patients, requiring mandatory monitoring of complete blood counts throughout the life of taking clozapine. It can cause seizures in about 5% of patients. Myocarditis is more common. Orthostatic hypotension and more likely syncope, excessive salivation, some of the other more common second-generation side effects such as weight gain. It can be very sedating, and it deserves a slide of its own in terms of its side effect risk. Moving on to talk about the antidepressants, these can be largely divided into the two major classes still in use today, the older tricyclics. There are some generic and brand names of the drugs that you may recognize, and then the newer SSRIs introduced in the early 1990s. And the newest one is citalopram, there at the bottom of the slide. They have slightly different side effect profiles. These are some other antidepressants that are neither tricyclic nor SSRIs. Some of them are SNRIs, serotonergic noradrenergic reuptake inhibitors. Nafazodone is a little used today surrounding some significant liver pathology. Trazodone is a very effective antidepressant, but it is so sedating that most trazodone prescriptions are really written as, in lower than antidepressant doses as hypnotics. But trazodone, if someone can tolerate the sedation and get the dose up to 3 to 4 to 500 milligrams per day, is an effective antidepressant. Bupropion is an antidepressant primarily with dopaminergic enhancing characteristics. The other, venlafaxine, mirtazapine, and duloxetine, are SNRIs affecting both noradrenergic and serotonergic functioning. In terms of looking for side effects or thinking about side effects, the tricyclics were very anticholinergics, probably more so than most of the antipsychotics, causing dry mouth, blurry vision, urinary retention. Could be anticholinergic enough that I think we could see a frank delirium in some patients, resting tachycardia. They were also sedating, could cause low blood pressure on standing, and as any antidepressant has a risk of switching a patient who is bipolar from being in the depressed phase to the manic phase. The SSRI side effects are better tolerated, but increasingly recognized. We've always known that they had some GI side effect and could cause in higher doses nausea and diarrhea. We now know there at the bottom of the slide that they can also cause frank GERD-type symptoms with GI bleeding, and increasingly this has been recognized to be a side effect of even moderate doses of some of the SSRIs, and certainly something to think about in our patients. The decreased libido and anorgasmia is typically not a big problem in the patient population with intellectual and developmental disability. It can be, but it has been less a problem. But what is a problem is sometimes the activation and agitation or insomnia if some of these medicines are used at bedtime and prevent people from sleeping. When they first hit the marketplace, we thought that at least some of them help people lose weight. We now know that the average person taking an SSRI will gain a few pounds, which seems to be a class effect. Here are a few other rare but significant side effects of some of the other antidepressants. As we know, trazodone can cause priapism, nafazodone, liver failure. There's a significant risk in the use of bupropion of exacerbating or causing seizures, and so it's a an antidepressant I think we don't use a lot in patients with ID, particularly those who already have a known seizure risk. The SNRIs can have a risk of hypertension. Mirtazapine has caused some appetite increase, and duloxetine has a warning about liver dysfunction requiring us to monitor liver enzymes in patients who are on duloxetine treatment. Let's move on now and talk about the mood stabilizers. They are lithium and all of the anticonvulsant mood stabilizers listed on this slide. I'm going to run through each of these quickly in terms of their side effect profiles. Lithium, as we know, can cause GI effects. There's a fine resting tremor. At higher doses and higher levels, cognitive impairment. We know about the thirst and polydipsia caused by lithium can cause a hypothyroidism in about 10% or so of patients taking lithium. And sometimes in a patient treated with lithium, we have to add a thyroid replacement. And then lithium causes a number of skin disorders. Carbamazepine, we know about blood dyscrasias. At higher doses and levels can cause ataxia, hepatitis with elevated liver function tests, thirst and hyponatremia, common side effect of carbamazepine, and some sedation. Divalproex, again, the GI effects, nausea, vomiting, again, a mild resting tremor. Most people taking this medication can expect to have some weight gain. It can cause a specific pancreatitis. That's typically been a bigger problem in young children taking Divalproex, but in someone who's complaining of pain who has significant GI distress, I think it's important to measure amylase and lipase to rule out the pancreatitis. Can cause some replaceable hair loss and then polycystic ovary syndrome. Lamotrigine causes a serious rash in about 1 in 100 kids, maybe 3 in 1,000 adults, and can be a significant and dangerous rash. It's caused us to slow down the dose titration. It looks like this rash is more common in children and more common in persons in whom the dose titration has been fast. So typically the way to avoid this is to avoid this medication in younger children and do a very slow dose titration. Other side effects there are listed for lamotrigine. Topiramate, a lot of fatigue, some dizziness, excessive sedation, and then probably the most significant side effect we worry about is confusion and memory dysfunction. This makes this a particularly difficult medicine to sometimes recommend for people with intellectual disability who already may have difficulty with confusion and memory dysfunction. And then it seems, cause as a side effect some weight loss through decreased appetite, and so is sometimes added to other regimens which have caused weight gain with the hope that individuals will be able to lose weight. These are the anti-anxiety agents. I listed all the benzodiazepines that you're familiar with, as well as buspirone and some common antihistamines. Benzodiazepine side effects that you're pretty familiar with are things like memory impairment, motor slowing, what used to be called a paradoxical disinhibition, in which the person would become agitated and sleepless. It's probably not truly paradoxical, but is a function of the benzodiazepine depressing the cerebral cortex, which is an inhibitory part of the brain, and letting the lower centers, which are more activating, take over, so that the person, instead of becoming calmed and relaxed, may actually become less inhibited and impulsive. Benzos in chronic use can cause clinical depression, and as we know, have a risk of tolerance and dependence. Antihistamine side effects you're also familiar with. These are the classic anticholinergic side effects: dry mouth, constipation, blurry vision, urinary retention, sometimes delirium. Most are sedating to a greater or lesser extent, but also can cause restlessness and confusion. And then I've listed here the common stimulants, the amphetamines in various forms, clonidine, a blood pressure medicine that seems helpful in some patients with attention deficit hyperactivity disorder, and then the newest non-stimulant, atomoxetine. It's stimulant-like. Stimulant side effects that you're familiar with are such things as headache, upset stomach, increased blood pressure, decreased appetite with weight loss, anxiety or nervousness, and then difficulty sleeping. Clonidine side effects, because it's a blood pressure and a hypertensive, can cause lightheadedness and low blood pressure, dizziness, but also dry mouth and some constipation. And then these are other psychotropics. I'm not going to get into them in great detail, but there is some history of use of beta-adrenergic blockers for behavioral treatment, opiate antagonists for self-injurious behavior, and cholinergics as treatment for some of the dementing disorders. So moving along now, as you may or may not know, there are only 2 current psychotropic medications with an FDA-approved indication in the area of intellectual and developmental disability. Risperidone and aripiprazole are approved by the FDA for the treatment of irritability associated with autistic disorder in children and adolescents. Irritability for those purposes has been defined as aggression, self-injury, tantrums, or mood lability. Other than that, let me go back for just a second. No other psychotropic medicine really has an FDA-approved indication, which makes essentially all other use of psychotropics in people with ID, I hate to hesitate to say this, but off-label, because these medicines have just really not been studied in a manner sufficient for the FDA to give a clinical indication in any other area of treatment in intellectual disability. So we'll talk a bit more about that later. Moving on to essentially talk about behavioral treatment. This is all previous slides have talked about the use of these medications when we were fairly confident about making a psychiatric diagnosis in a person with an intellectual or developmental disability. But because so much psychotropic treatment in persons with ID has not been disorder-based, but has been symptomatic or symptom-based, the World Psychiatric Association several years ago got together a panel of experts and came up with some consensus guidelines. What they provided are over 50 specific guidelines for treating behavior disorders in the absence of a psychiatric diagnosis. So if you can't be confident that your patient has a psychotic disorder or a mood disorder or an anxiety disorder or obsessive compulsive disorder, but might benefit from a psychotropic treatment of their symptoms, such as aggression or self-injury or some other symptom, here are some guidelines from the WPA in terms of addressing and monitoring that. Once a decision to prescribe a psychotropic is made, there needs to be a arrangement for an appropriate follow-up. We should use a single medication at a time and use those medications only within recommended doses. We should start low, titrate slowly, and use psychotropics at the lowest required dose and for the minimum amount of time necessary, and make a consideration for withdrawing medication on an ongoing basis. This is a bit controversial, but the WPA really took a good look at whether it looked like people with ID were more or less likely to have adverse events, AE, than using psychotropic medications compared to individuals without intellectual disability, and ended up concluding that there really was no quality evidence to either support or refute that people with ID are at greater risk. We know that people with ID are at greater risk for having AE missed by their clinicians because they have less capacity to tell us when they're having a side effect. So that certainly if we're prescribing psychotropics, we need to have a much higher index of suspicion and do a better job of looking specifically for the side effects that I've outlined on the previous set of slides, and really go through all of those side effects with the patient, if possible, with the caregivers at every visit, about whether there's any evidence that the person with ID who can't tell us about their side effects have any signs of any of these side effects. So we know that side effects or AE are missed. What we're not sure about is whether they are more or less common. we can assume they're at least as common, and therefore we need to look for them to a more vigorous extent. We need to obviously therefore discuss with the patient and the family the common and serious AE that they should be looking for, advise what action to take if there is one, and record all AE properly in the patient's medical record. In terms of considering add-on medication, if we're going to be adding on one medicine and continuing the first, we need to have well delineated the reasons for a second medication. We should almost never use two medications from the same class. That's been described as intra-class polypharmacy and is generally thought to be not a good idea or not best practice. If the combination has been effective, but when a second medicine has been added, we should try to withdraw the first and return to monotherapy as soon as is clinically possible. It's best to avoid using two medications for the same clinical indication. If we're going to do something like this, it's better to obtain a peer review and present that case, or actually have that patient seen by a second clinician who can render an opinion about the wisdom of doing that. And then the WPA concluded that the use of more than 3 medicines simultaneously is pretty difficult to justify unless you're treating epilepsy, which often requires more than monotherapy. Here are some general psychotropic recommendations, and then we're going to sum up and hopefully have some time for questions. Beyond the WPA guidelines, this would also be, I would consider, a take-home message slide in terms of general psychotropic practice, avoiding frequent drug and dose changes. One of my old professors used to like to say, in terms of giving advice to practitioners, the brain changes slowly, and so should we. Making drug changes very slowly and making dose changes slowly, those activities should be avoided. Frequent drug and dose changes should be avoided. We should obviously try to minimize long-term use of any PRN psychotropics. Some jurisdictions have totally outlawed the use of PRNs. My personal belief is that in certain settings and with appropriate limits, PRNs can be helpful, but that's controversial. We should certainly try to minimize their long-term use. We should avoid the long-term use of benzodiazepines and avoid the long-term use of sedative hypnotics in patients with ID. We should try to minimize the long-term use of anticholinergics. These medicines are often given for the extrapyramidal side effects of the antipsychotics, but it's been shown in many studies that often, even if a person had EPS and needed an anticholinergic at one point, these medications can be later tapered, withdrawn, and the person will not have the return of the EPS that they once had. So that we should make attempts to get people off these anticholinergics with all of their own side effects, whether somebody has or does not have extrapyramidal side effects. We should minimize the use of high-dose antipsychotics, avoid the use of diphenylhydantoin or barbiturates used as psychotropics. That's really kind of outdated practice. And as we've already talked about, avoid the use of intra-class polypharmacy. Inter-class polypharmacy, I think, is fairly accepted, so that if a person needs a mood stabilizer and an antidepressant, or a mood stabilizer and an antipsychotic, or an antidepressant and an anxiolytic, with proper monitoring, those inter-class polypharmacy is acceptable practice, but intra-class polypharmacy is something we should try to avoid. So in summary, people with intellectual and developmental disabilities can and do suffer from the entire range of psychiatric illness. We've talked about some illnesses and disorders that are more common, a few that are less common, but it doesn't look like having an intellectual disability really protects you from and may actually predispose people to having types of psychopathology. We think psychiatric illness in our patients is common and, as we've talked about, often difficult to diagnose, and that treatment approaches, unfortunately, as a result, are often symptom rather than disorder or etiology-based. We've highlighted, I hope, that before a clinician can try to differentiate a psychiatric from a disorder, from a behavioral disorder, that there must be an investigation for the presence of a medical illness or a medication side effect that may be presenting as a psychiatric or behavioral problem. that behavioral problems can and often do coexist with psychiatric illness, so it's not really an either-or issue. They commonly are coexisting. That psychiatric or psychotropic medicines should be only one part of a combined treatment plan utilizing behavioral and psychosocial treatment, and that when we do use psychotropic medicines, they should preferentially be used to treat a specific psychiatric disorder rather than symptoms. And with that, I will say thank you again to Dr. Holder, the AADMD, the Florida Council, and committee, and thank you to the audience, and I'll be glad now to try and entertain any questions you may have. Thank you.
All right. Thank you, Dr. Rudrick. Would you mind putting us on the last slide? I just want to go over how people can get their certificate really quickly before we go on to questions, in case anybody needs to jump off early. In order to get your certificate, just go to the link up there on the screen. Also, there was a question about how to download slides, and these slides will also be available at that website. So it's bitly.com/PEDD 2012. From there, you sign in or register. If you haven't registered already, once you do, you will get an automatic confirmation email. And if for some reason you don't see it, check your spam folder, because sometimes that happens. If you have any issues with signing in or registering for the system, just contact us. Go to the aadmd.org website and hit the contact button, and one of us will help you. From that site, once you're signed on, you can complete our survey, which we encourage everybody to do. And you can also take our quiz. The quiz passing score for the quiz is 7 out of 10. And once you pass the quiz, you will be able to get your certificate, and it will be emailed to you automatically as well. Okay, so we had some interesting questions. I think some of these you touched on, but I'll probably repeat some anyway, because I think it's very interesting. The first one was about well, Fragile X and autism, and this was just wondering whether or not that, well, the actual question is, I've seen a few patients that have Fragile X and also have autism. Is there a correlation between the two?
The easy answer is yes. Autism is a very, very common comorbid condition with Fragile X. I would, I'm going to guess. Now, again, probably our capacity to accurately identify Fragile X in large populations is really something we've only been able to do in a widespread fashion over the last 10 to 15 years. So we don't have a lot of older studies of this. And some of the newer studies, it looks like some autism spectrum disorder affects at least 50%, if not more, individuals with Fragile X. Another common comorbid condition is attention deficit hyperactivity disorder, and so often you have both of these things going on, fragile autism and an ADHD diagnosis, and other comorbid conditions are anxiety disorders and mood disorders. But the easy answer is yes, common comorbidity.
Okay, great, thanks. There's another question about diet and behavior, and the question is, well, is there much of a correlation between diet and behavior? And then the follow-up is, for example, does a gluten-free diet work?
This is a very controversial area, and I try to stay up with the newest stuff with regard to diet and behavior. The mainstream position of most of the organizations who serve people with intellectual disabilities, the NAD, the AAIDD, the American Academy of Child and Adolescent Psychiatry, the American Academy of Pediatrics, is that there are not specific diets that result in or fix or address specific behavior disorders. There is a lot of interest in a number of elimination diets as it may affect hypersensitivities or food allergies. There have been, as you know, a number of diets that have been aimed at attention deficit hyperactivity disorder, have been aimed at autism spectrum disorders. I guess my broadest answer to your question is that the state of the art today is that there is no specific recommendation about diet that I'm aware of from any of those major medical groups. However, in select individuals, in select circumstances, I think specific types of diets can be useful. And I talk with parents and or caregivers on a regular basis about their willingness or interest in attempting a gluten-free diet, in attempting a high carbohydrate diet, and attending a fatty acid high fatty acid omega-3 diet. So I think that if you're going to try a dietary intervention, it's good to jump into it and really give it a fair shake. That should be a time when you're doing a lot of monitoring. You're hopefully using some specific instrument to monitor whether the person has improvement or lack of improvement, and really give it a several month shot. You should try not to be changing other psychotropics or living situations or work situations or other variables at the same time that you're trying a dietary intervention. Now, having said that, I mean, there are certainly diets, for example, in phenylketonuria, where diet is clearly related to psychopathology, and we think that PKU folks who are able to follow the PKU diet are much less likely to have behavioral problems and psychopathology than people who aren't able to follow that diet. But broadly speaking, this has not been something that's been shown to be of significant help in the mainstream.
Do you think that, kind of as a follow-up, that there is a correlation just between general nutritional status, just having a sort of a better nutrition, a better overall nutrition that may impact behavior or provide improvement versus, let's say, a not so nutritious diet?
Yes, yeah, absolutely, Dr. Holder. It's clear that having a general balanced diet promotes mental health and deters psychiatric and behavioral disorders, and that unfortunately many of the patients we see and serve with intellectual disability may have very idiosyncratic dietary habits, and as a result of that can develop specific nutritional deficiencies. So that I think, particularly if you hear in your patient that there are dietary idiosyncratic, this is somebody who won't eat vegetables or only eats yellow food, or you hear a very specific, loves junk food, won't eat their vegetables, won't ever eat meat, something like that. It's good to do metabolic screens looking for specific nutritional deficiencies, vitamin deficiencies, and certainly in that patient, and perhaps in all patients, taking a general one-a-day multivitamin just to make sure that you're covering all of the dietary nutritional needs in somebody who's not getting a general balanced diet.
Okay, great, thanks. We have a sort of a two-part question. I think this came during your discussion on antipsychotics. And the question is, it's a two-parter. Are drug-induced extrapyramidal symptoms reversible, and are the metabolic effects of second-generation side effects permanent?
Excellent questions. Drug-induced EPS are all of the acute drug-induced extrapyramidal side effects, that is, acute dystonias, akathisia or motor restlessness, and drug-induced Parkinsonism are all reversible. So that if you see any of those side effects and your patient can tolerate being off the antipsychotic medication, taking them off the antipsychotic medication makes all of those acute extrapyramidal side effects go away. The other acute EPS that I didn't mention in the slide but can be life-threatening is something called neuroleptic malignant syndrome. Those are people who develop a fulminant extrapyramidal course with rigidity and fever and elevated white count and labored respirations and can sometimes be fatal. That also requires us to quickly stop the offending antipsychotic. So all of the acute EPS, dystonia, akathisia, drug-induced Parkinsonism, and neuroleptic malignant syndrome, hopefully, are reversible with interruption of medication. The other EPS that may not be is something called tardive dyskinesia. Tardive dyskinesia are movements, typically oral lingual movements, which can develop after years or decades of exposure to dopamine blocking medications. And many times when those dyskinetic movements show up in somebody who's been on an antipsychotic for a long, long time, tapering and getting them off that antipsychotic can reverse those movement disorders. And then we look back and say, well, that person had a withdrawal emergent dyskinesia, that we were able to withdraw them from the antipsychotic, and over time those side effects went away. Unfortunately, some of the late appearing tardive dyskinesias can be irreversible. So even if you take the person off the antipsychotic, they may end up with one of these movement disorders, typically tongue thrusting or a chewing movement, or sometimes facial grimaces. So tardive dyskinesia is really the only extrapyramidal side effect that is thought to be possibly irreversible. As we know, the second generation antipsychotics cause probably only about a third of the extrapyramidal side effects that the first generation antipsychotics did. So it's a smaller problem, but it's a problem even in people with who are taking second generation antipsychotics. The second part of the question was, is the metabolic syndrome permanent? The easy answer to that is we don't know, frankly. It looks like most of it is reversible if we are able to stop the antipsychotic, second generation antipsychotic offender in time, that people are often able to lose some of the weight that they gained taking the second generation antipsychotic. Their insulin resistance may reverse. I've had people who clearly had a hyperlipidemia on a second generation antipsychotic, and if we were able to take them off that and treat them in some other way, their cholesterol normalized, or their elevated sugar normalized. There do seem to be a cohort of patients, however, who once they've gained the weight on the second generation antipsychotic, even if you can get them off that offending agent, that weight is tough to get rid of, and whatever consequences it has in terms of hyperlipidemia or glucose intolerance may be lasting.
Okay, great. Thank you. We have another question, and I'm going to preface this one by telling you that you're talking to a group of primary care physicians, so be gentle with the next question. But the question was, what are your thoughts on primary care physicians versus psychiatrists prescribing psychoactive drugs in terms of the quality of the care that's being provided?
That's an excellent question, and it's very easy to answer. Essentially, we have no choice. That's not meant as being any kind of disqualification, and obviously we would like all primary care physicians to educate themselves and be knowledgeable about psychopharmacologic practice. But the truth of the matter is, there just aren't enough psychiatrists to serve the patient population, either in the who need general psychiatry, or specifically who have intellectual disability and psychiatric illness and behavioral problems. So we are very reliant as a field on good primary care physicians and nurse clinicians with knowledge and expertise in psychopharmacology. And I think that's why things like these World Psychiatric Association guidelines present a very good evidence base for the primary care physician to be able to feel comfortable and safe in approaching a psychopharmacologic practice. In my experience, primary care physicians are very good at this. They are comfortable with the medications. They're aware of and knowledgeable about the side effects. they may struggle a bit when you get into intraclass polypharmacy, and at that point maybe want to get a psychiatric opinion or make a referral to a more specialized clinician. But in my experience, primary care physicians are very good at this. We rely on them heavily, and frankly, they're prescribing many more. The bulk of prescriptions for psychotropic medications of all types are written by primary care physicians and well.
You mentioned the World Psychiatric Association guidelines, and I think they might apply to this next question, but this came to us from a caregiver who has a patient who is older, in his 40s, with intellectual disabilities and CP, and he's on Zyprexa, and he just got a new psychiatrist. And the caregivers, I think, have been noticing that he's had some handshaking, and there was a suggestion from a behavior analyst that perhaps they should think about weaning him off or reassessing him. But the psychiatric, I guess the doctor they've taken him to isn't sure that they really want to do that, because they're not sure if they don't want to, I guess, fix what's not broken, to quote the question. So, in your opinion, how do you think the caregiver should go about interacting with this doc to, address these issues, to address their concerns?
Again, an excellent question, and something we deal with here in our clinics at Case on a very regular basis. The tremor that you're seeing in your patient could be from a variety of sources, including being a side effect of olanzapine. I'm not sure that your person is taking any other psychotropics, but many medicines can cause tremor of various kinds. Could be tremor from some other etiology. But I guess the position I would take, and I'm going to go out on a limb here as well and say it's important that the clinician be able to see what you are seeing as caregivers. And so something I urge caregivers, families to do all the time when they see any kind of movement disorder is to videotape it, and come to the appointment with the videotape and ask the clinician to take the time to look at whatever it is that you're seeing. So, because often when the person is in the office, the clinician doesn't have an opportunity to see what you're seeing in the patient's natural setting. So the beauty of video is that we can capture abnormal movements, tremor, dyskinesia, whatever, on video, and show them to the clinician. You can email them to the clinician, but I think it's important to try and bring that to the attention of the clinician. I guess my perspective on this is, if the patient, any patient, is having a side effect which is distressing to them or distressing to their family or distressing to their caregivers, that it needs to be addressed by whoever the clinician involved is. And if and a recommendation can be made that this is really getting in the way of the person's life. It's tremor may be preventing them from being able to feed themselves adequately or dress themselves adequately, or they may not be doing their job as efficiently as they were, or they may be reluctant to, they may give up their bowling game or something or it may be embarrassing to them. So that if the side effect, whatever it is causing the individual or their family or their caregiver distress, then I think it's reasonable to try and do something different. The change could be, let's just try lowering this medicine. Maybe they don't need the same dose they needed for a while. And maybe the side effect is a dose-dependent one that will be decreased if we can just lower the medication. Can we substitute some other medication for olanzapine that might be less likely to cause tremor? So I think everybody deserves at least one opportunity to have, even if they're in a stable remission, to have a medication reduced or replaced if it's causing a side effect that's causing some distress. Having said that, my typical rule of thumb is, if we make that medication reduction and Maybe the side effect gets better, but the underlying symptoms that were the original justification for the medication comes back, and it's, that illness or disorder or behavioral problem is worse, and we can't address it as well as we did with the whatever medication, olanzapine or whatever medication, is that we've at least, given it a try to do something other than just kind of say, I don't want to rock this boat.
I couldn't agree with you more. That was a great answer. I hope that, well, I hope whoever asked it actually is still listening, because that was great. And I think it's very much in line with what you presented and with the World Psychiatric Association guidelines as well. I was really glad to see those. I was not aware of the association, actually, so I got to learn something tonight too. I would like to thank you, Dr. Udrich, for giving us a great, fabulous presentation tonight, and staying around for a little extra time to answer questions. So thank you very much.
You're welcome. Thanks for listening.
Yes, and I'd like to thank everybody else for staying on and attending tonight's installment of our webinar series. And please remember that in order to get your CME certificate, you need to go to the website on the screen. And if you have any questions or concerns, you can email me at mattholder@aadmd.org. And our last webinar in this series is going to be next Tuesday at 6 p.m. Eastern Time. And it will be on a topic that I'm sure will be of interest to anybody treating patients with IDDD or helping to design a system of care for them, and that is on healthcare financing. So from all of us at the AADMD, thank you and have a good night. Thank you, Dr. Rudrick. Have a good night.
Thank you.